Well, we're
have to pass them on.
You never know.
I have several, we saved some for the board members. Okay.
All right, good morning. We'll call this Board Insurance Committee meeting to order. Superintendent, if you would, please call roll.
Mr. Lejeune?
Here.
Ms. Mason? Here. Mr. Hidalgo?
Here.
Let the record show also Mr. Chad DeZormo's here. He is sitting in. I encouraged all board members to come if they were able to, as far as their schedule is concerned. So, Mr. DeZormo, thank you for being here. We have a quorum.
Thank you, sir. A couple of housekeeping before we get to the agenda. Welcome, everyone. Thank you for being here. Today is expected to be a very, I guess, eventful meeting as it relates to a lot of data, a lot of information, a lot of research. What I'll ask, normally during committees, we'll set it up to where public comment, folks can ask questions. Because of the data overload today, we're going to do it something a little bit different. We are going to stick to public comment. So when we have an item on the agenda that action has been requested, meaning there's a motion and a second, anyone from the public can come up and give public comment, meaning speak for or against the specific item, the motion on the floor. Today we're not going to do question and answer from the mic. However, if you look at the far end of the boardroom where I'm pointing here, there is a podium. On that podium is a notepad, and at any time during the meeting, if you hear something, or if you already know you have a question, you're welcome to get up now, go write your question down with your name, and we're going to periodically have someone check that notepad and try to get those answers for you immediately here today. If there's something that you ask that we don't have an answer for, we will follow up, whether or not it's a phone call, an email, or the subsequent meeting. So please keep that in mind. We're not going to be rude, but we are not going to be taking questions from the microphone. Yes, I'd like them to put their name. If you want to put your email address, that's fine, but at least your name. All right, item 2.1, review and approval of Lafayette Parish School Board Insurance Committee meeting minutes on August the 7th. Can I get a motion to approve those or any recommended changes?
Motion to approve. Second.
I'm going to need Mr. Lejeune to second that.
Second it.
All right. And, well, we'll do it after the roll call. Any public comment on the minutes from the August 7th Board Insurance Committee meeting? Hearing none, please call the roll.
Mr. Lejeune?
Yes.
Here.
Is that a yes? Okay.
Mr. Hidalgo?
Yes. It's 3-4, none against. The motion carries. I'd like to acknowledge that Mrs. Kate LeBeau is with us here today as well. Thank you very much for showing up. It's an important meeting. Item 2.2, discussion and or action regarding the Insurance and Benefits Department staff report. Ms. LeBeau.
Good morning, everyone. My name is Trish LaBeouf. I am the Director of Insurance and Benefits. We're going to do something a little bit different this morning than the traditional Board Insurance Committee agenda items. I'm going to speak this morning just to try and draw your attention to some of the important pieces that the Gallagher presentation will have today within their presentation. I want to make note of it in my staff report, just so that when they speak on those items, it catches your attention and you realize that it's important. Last time at the last Board Insurance Committee meeting, I was asked about the Ochsner claims reporting that was on a lag. Let me try and scroll that down for you. It was on a lag, meaning there was a negotiated agreement between Ochsner and Blue Cross. They were trying to work it through. It took some time to work that negotiation through. Based on that time, there was a lag in claims and billing, meaning that they held on to the claims and they didn't push them through until later. They actually pushed them through from March to May of 2024. I was asked to bring additional information so that you could physically see those claims that processed through. We did do a double check directly with Blue Cross Blue Shield. When we did our double check, Blue Cross verified that those claims have completely processed through as of June 30th, 2024. The amount that those claims were $1.4 million. So I just wanted to, last time you had asked me for a follow-up, I wanted to provide a visual for you when I came back today, and then verify that Blue Cross has certified that those claims and billing have processed through. We've already paid the bills on them, and that claims are finalized as of 6/30/2024.
Miss, do you recall what the projection was for that time period?
They couldn't give us a projection. That was the problem.
No, our projection. You know, throughout the year, we have a monthly projection. Do you recall? I don't.
So the week that you see 5/27/24 with the Ochsner claims of 1.173201, that week was a $1.8 million week. So obviously that blew out our projections. There, when we were working through claims and billing and we're projecting for that particular fiscal year, we're taking the average of the prospective months based on how claims are processing through. Because they held on to those claims, that was an unusual week. On average, our claims and billing shouldn't be any more than about $850,000 per week. So to have a $1.8 million week was huge, if that helps put it into perspective. The given weeks during that time period, the actual bill on the 5/24 bill, it was $1 million. On the 6/14 bill that we actually paid out, it was $1.1 million. So just to keep it in perspective, those portions are the lag claims that they held on to and then pushed through during the months of March through May. The next item on my staff report is open enrollment. Typically this time of year, we're already communicating with members and we're telling them that it's time to make changes to their benefits during the open enrollment period. Open enrollment allows them to either add or cancel benefits during that time period. This year, there's a little bit of I'm going to call it a wrench, because we did elect a new group health insurance consultant. The consultant had to properly review and advise our health insurance plan and all the intricacies with it. Based on that, we're going to have to delay it, because that will become apparent in subsequent conversations that Gallagher will come up. I'm going to come up later and add some more detail to this. But open enrollment hinges on your Blue Cross Blue Shield, and it hinges on your pharmacy benefits, and it hinges on everything that Gallagher's going to talk to you about today. So as a result, we're going to have 2 open enrollment periods this year. We've pushed open enrollment backwards. Typically, it's about mid-September to mid-November. This year, voluntary benefits, keep in mind, voluntary benefits are any other benefit other than group health insurance. So it's your dental, your cancer, your short and long-term disability. It's any of those 13 voluntary benefits. Each AGM and Hub will be going out to every single school location during the dates of October 1st through November 8th. October 1st through November 8th. We will have voluntary open enrollment separate from group health insurance. We will have to pause on group health insurance until we get direction from the board with regard to the presentation that's going to come to you today. Based on the, we did listen to members during the voluntary benefit open enrollment. AGM and Hub has worked with us, and typically what happens is members have to visit with AGM and Hub to recertify their benefits for the following year. We're also offering online options this year and phone options, which is a great additional add. It's going to help with keeping your staff focused on the task at hand during the workday. They can perhaps accommodate through a phone or an online verification for their benefits. So I found that as a very wonderful value-added benefit that they're going to have. So my instructions are, A, be on the lookout for our communications. They're going to come in lots of different forms. Because there is 2 open enrollment periods this year, it may get confusing. So please pause, take a look at the communications, whatever that is, so that you don't miss the deadlines. The deadlines are going to be super important. With regard to open enrollment, we typically send out emails to your work email address. You're going to have a postcard to your home address. We send out text messages with clickable links. It's listed on our website. Supervisor, we do flyers in break rooms. We try numerous different touch points to include adding it to our website. So members are, I'm touching numerous different staff members based on what their job description is. Perhaps a custodian is not always checking their work email. So please be on the lookout for those communications that come from our office. They're going to be super important. I don't want anyone to get sideways on when those deadlines are so that they can make changes. Please also, once we work through this process by presenting today and we get direction from the board, please be on the lookout for additional communications with regard to group health insurance. That will be coming your way. It's going to land primarily in your work, LPSS work email address. Questions?
Tricia, I have a question. Just so that the board insurance and the rest of the board members know, what is your date of which you need to have something go to the board so that they know backwardly what needs to take place from that point?
I'm going to detail that out for them in just 2 seconds. You're ahead of me. My next staff report is with regard to the Gallagher contract. I just want to give you an update. The board approved Gallagher as our new group health insurance consultant at the 7/31 board meeting. We immediately began that contract on 8/1. They have been diligently working, looking at our data for the last 6 weeks to come to you today to present all the options available to you so that you can make decisions to make recommendations to the board. Keep in mind that agreement is a 1-year agreement with a 1-year option to renew based on LPSS's request to renew. So just key pieces there. I wanted to give you an update with regard to the contract. And then I wanted to touch on some important pieces that I want to draw your attention to that will be within this Gallagher presentation that will be happening in a few more agenda items. So obviously they've reviewed and assessed it over the last 6 weeks. Based on our financials, there are growing deficit concerns, okay? So based on that, they're going to offer some recommendations to you today. It's going to, the contracts that the superintendent signs off on is associated with all of the decisions that are being presented to you today. So they're going to present the information. There will need to be a recommendation. It will go to the board, and we will need board direction to move forward. This affects not only your contracts which are effective January 1st, but it also affects, I apologize, I lost my train of thought. It also not only affects your contracts, but it affects open enrollment. So please keep that in mind as they're talking through the presentation today. Keep that to the top of mind. Decisions will need to be made on medical, the Medicare Advantage, and cost savings alternatives as a recommendation to the board. Okay? It also affects, like I mentioned a moment ago, the superintendent signs off on contracts, he reviews them. It alternately affects the pharmacy and the stop-loss contracts, which he needs to sign off on them almost immediately and prior to 10/1 on a large majority of our contracts. I do have input within the information today that I'll go into more detail on about later on. The recommendations today are optimal if we can offer a recommendation. However, there is a 10-2 Board Insurance Committee meeting, just bringing that to your attention. The department obviously will need action by the board at the 10-9 board meeting at the latest, okay? We have requested extensions, I just want to put that out there, of the providers. There's no more extensions. If you essentially don't want, we looked at the membership base and I wanted to put it into perspective so you could see how important this is. There are 9,939 members. That includes your active members, your retirees, and their dependents. 9,939 that if you do not take action on, we have cause for concern because that's your health insurance contract. Gallagher's going to offer some recommendations for you. That's the pharmacy benefits. Members will be without pharmacy benefits. So I want to bring it to your attention of the importance of it just so that you know the impact of it. We also need time to communicate with members. You certainly don't want to be making decisions. We rush them in order to make a decision, and they're totally confused. So I need a little bit of lead time, and we are as much prepared to immediately send out communications as we possibly can, but I need time to make sure that we communicate effectively so that you don't have members missing their deadlines, okay? So I just wanted to bring that to your attention as you listen to the presentations today. Please keep that top of mind within today's presentations. Any last pieces that I have within my staff report is I just wanted to give you an update. Last time we were asked by the Board Insurance Committee to send out a retiree communication to, again, just remind those retirees, communicate with your fellow retirees, remind them to stay connected with the department. That way, department communications can land at their doorstep. Again, we are more than willing to communicate with loved ones if you would prefer to add a staff, if you prefer to add a loved one's email address or perhaps their text information. Our primary form of communication is electronic. We do send phone, we send email to their personal email address. We do also add it to the LPSS department website. That way, if they don't have an email address or they don't want to give another email address, they can pull it up on the department website and everything is listed under department communications that we send out on a regular basis to our retirees. So I just wanted to give you an update on those staff items that I had. Do I have any questions?
Regarding whether it's actives or retirees, those that the email or the text message communications have kind of been lost somewhere, we've done a couple of mail outs over the past several months. Is that correct?
We sent out a mail out about a month and a half, 2 months ago that asked for that point of contact information. There was over 600 members that we did not either have a text option available to them or an email address. That's when we asked them for their input. If they did not have one, we asked for a loved one's point of contact information, and then we also gave them the resource of the website.
What's the feedback from that?
Dana, can you come see for a moment, please?
Oh, yeah.
Can you just give me a head count as to how many of those we received back?
We have received about
Speaking.
200,
Hold on, here.
we've received about 265 back.
Good, good, thank you.
Thank you.
Ms. LeBeau?
Trish, I know as my dad's power of attorney, I need that in place to be able to communicate. Do we, can we communicate to them what they would need and the importance of having somebody as a backup for the retirees? And do we provide maybe a form or any of that information so that they understand if we are going to have somebody on their behalf making decisions or having to communicate what is required for them to access the information or be able to, I guess, make changes or make decisions?
So I'm happy to communicate in any form. However, you're correct. We would need some sort of POA on file if they were making decisions on behalf of, and it would have to be in our electronic records. We can certainly communicate that additional piece of information if they are acting on behalf of a member. But typically, I will update an email address for a loved one. Like if a parent wanted their child to be listed, we can change it in our records to communicate directly with the dependent. So I don't have a problem making that change. Now, if it's that requires legal with a POA or something like that, then yes, that would have to be on record for the member in our files.
Yeah, can we just maybe include that in some of our correspondence, just because I know, you don't expect your loved one to have losing capacity, but it can happen at any moment just for a brief period of time, and it'd be great if we could have somebody aware that they could be available to help make those decisions during that time. Thank you.
Yes, ma'am.
Any other questions regarding this agenda item? Okay. Thank you very much, Ms. LeBeau. We'll move to item 2.3, discussion and our action regarding the Fund 85 budget report.
That's me. Good morning. Okay, so hang tight 1 second. Let me put up the fiscal year 23-24 budget, and we'll just review it. So it takes a bit to close out each fiscal year, which is why last time when we came, we didn't have a lot of information for you because there's run out claims information that we have to finalize each account with. We are now to that point where we have finalized fiscal year 23-24, and I have information available for you. Okay. I'm going to draw your attention. I'm going to work through the footnotes is what I'm going to do, and then let me know if you have any questions. So footnote number 1. So we have reconciled with not only the Fund 85 accountant, but we've also reconciled with Gallagher since they've come on board. We all have the same account of closeout for fiscal year 23-24. So I feel confident with the numbers that we're presenting to you today. The number 1 footnote is actually, you're going to be approving this budget to actual number 6 final at your board meeting this evening at 5 p.m. So I was just trying to draw attention to the fact that it's essentially the same thing that you'll be approving later. So footnote number 2 is the final deficit for fiscal year 23-24. Keep in mind, that's ending 6/30 of 24, okay? $7.9 million deficit is where we have landed for the year. I want to draw your attention to footnote number 3. If you'll remember previous conversations that we've had, we've discussed that $1.2 million pharmacy management fund from RX Benefits. We talked about the contingencies attached to it, that if we canceled that contract, we'd either have to give back the full sum or it would have to be prorated on $100,000 per month based on whenever we canceled it. The district did receive the $1.2 million from RX Benefits. Had we not, I wanted to draw your attention to the fact that your deficit would have been $9.1 million, ending fiscal year 6/30/2024. Footnote number 4 is, it's been increased, the account for the consultant fee has been increased because the district is working through an audit and reconciliation of all of our pharmacy benefits with Express Scripts, with RX benefits, and with Silver Scripts. Based on that audit, let me scroll down. Based on that audit, the district could receive additional funds if the pharmacy managers did not meet our contract terms. So I just wanted to draw attention to that the district does stand to hopefully, if the pharmacy management providers do not meet those terms, then we could receive additional refunds from it. Footnote number 5. So now let's discuss fund balance. I took the $7.9 million that we just discussed, that we ended the fiscal year with. The next line item is your fund balance. So beginning 7/1 of 2023, we had a $4.3 million fund balance. Obviously, if you take the 7.9 deficit from the 4.3, we're landing at a $3.6 million fund balance as of 6/30/2024. Based on a transfer from the general fund of $6.6 million, we now have a fund balance of 2.9. So let me help clarify why we have a fund balance and why it's needed. So obviously, you could see the 5 footnote, which shows that there was a transfer from general fund. The 6 footnote tells you that we still have closeout claims that are coming through. So when a member goes to the doctor or they have a procedure at a hospital, it takes a bit to hit our claims and billing. There's a lag. So upwards of 4, 6, sometimes 8 weeks or more. Based on that lag, we have asked the general fund for additional monies, which you'll see with the 2.9. I fully anticipate, based on the lag of claims that still need to be audited by our external auditors in the fall, that 2.9 will also be depleted with the possibility of there being more. So keep that in perspective. So the 7.9 could turn into a larger deficit by the time that the auditors finalize your books and close everything out at the end of this year. Any questions on any of that?
First, thank you. I love the way that you laid this out. I see it just a tad bit different. I'd like to
Okay.
spit it out, and I want you to tell me if I'm wrong. You say we have a $7.9 million deficit. I say we have a $9.1
9.1.
million deficit. Because are we guaranteed every year to get $1.2 million from this RX company?
No, sir.
No. So, we were fortunate enough to get it, which landed us at 7.9. But before that lucky charm fell from the sky, it was 9.1. And I also want to point out that the 2.9 that's in the general fund, which is going to be looked at as a windfall or an emergency savings account, is going to be spent. That's just money committed, money pulled over because it's going to have to be, the check's going to have to be written. So it's not money in a savings account, to go to Holly Beach. That is going to be spent on medical claims that are just still. What takes so long on some of these claims?
It's just claims and processing. It does take a bit. It's got to
But we're
work
in
through Blue
September.
Cross. Some members who have Medicare, it would have to go through Medicare first, then Blue Cross. So there is it's a time factor. It does take some time.
Okay. Thank you for laying it out simple like this. And I understand that it takes time to get the numbers, but thank you for laying it out this way.
You're welcome. So I want to segue just a bit. Yes, ma'am.
I assume if we're undertaking an audit, we expect to get something back from the prescription claims. Do we have any idea what that estimate might be?
It will be, we have, I don't want to make any promises,
Right,
but
no,
yes,
I-
ma'am. We are expecting what we have at least paid and then some. Yes, ma'am.
Okay.
I don't have an exact number for you.
Can you ballpark
which is
it?
what I
Maybe
think you're
kinda-
looking
I know
for.
you're not tied
I
to
don't
this
know that
number,
I
but-
want to throw out a
Okay,
number,
okay.
if you don't
And,
mind. I
and
would
what
hate to
about
be wrong.
denials? Are those denials handled by us if there's a denial, or is that handled by the individual?
Say that again, like a
I
claims
guess if
denial?
If there's a denial of a claim, the appeals process is through the individual, or do we do anything in our department to help with?
We do have an appeals process. It does have certain levels.
Okay.
It's got to go through level 1. When it does hit the district on a level 2 appeal.
Okay. That's
Okay.
what I was- yeah.
Typically, what I do at that point in time is I defer to the experts.
Okay.
And we pay to have an external review by an educated and experienced doctor, physician who knows better than I do,
Yeah.
that knows better than the district does. We will pay for that through our fund in order to make sure that that member gets a correct response.
Okay.
I wouldn't feel comfortable telling a member no on something when I do not know what that procedure is or the circumstance or anything.
Yeah,
So the
absolutely.
district does pay for those second-level appeals when it does hit our doorstep, and the member can check off that they want an external appeal, and then it will work through that process, and then the district pays for it.
Okay.
And then the member gets their response, whatever that response is the last and final response, and there's no more.
Okay, great. Thank you very much.
Tricia, I want you to kind of point out for the board members and the public, what is the total amount of money that we had to transfer from general fund to this fund to be able to make sure that it is where it needs to be?
You're 2 steps ahead of me, Mr. Touchette. Okay, so that was my segue piece. I'm going to tell them. So I did ask for authorization to talk you through your fiscal year 24-25 budget today, which will answer the question that the superintendent just asked. Because it's already going to be covered as a summary within the Gallagher report. I know we're going to be here for a lengthy period of time. There's a lot of content today, but I wanted to give you a bottom line so that you can keep that in perspective when you listen to Gallagher and their presentation. So we have been working through the last 2 months of claims and billing. It typically takes like the first quarter to get better projections based on the data that's coming through for the remainder of the year, okay? So based on that, when Gallagher presents their presentation to you later, they are going to state that the district right now, when we reconciled, when they audited, when we all came together, the accountant, insurance, and Gallagher, they are going to present a $7.6 million loss, is what they're projecting right now for your deficit for 24-25. But I want to put a huge disclaimer on that and remind you that when we work through the budget process, the board has already approved $6.6 million of that 7.6 total that Gallagher's going to tell you about in their presentation. So if we keep it in perspective, if that's the case, then you're looking at $1 million right now. And the reason why, when we worked through the budget process in April, keep in mind that was a couple months ago, your enrollment that you have on the plan is always fluid. You have members who are coming on and coming off. So the numbers that are in April are not going to be the same numbers for today, okay? So when we built your budget and y'all approved it, based on that, we were projecting 6.6. Based on the enrollment numbers that you have today, we're looking at a 7.6. So I wanted to give you a quick little summary. I don't have a one-pager detailed report for you. I plan on bringing you back some details. But in the interest of time and the fact that Gallagher was going to go through all of your financials today, I wanted to front-load a few things that you need to pay attention to when they're presenting their Gallagher report with regard to financials, and then also keep it in perspective so you don't become alarmed that you're hearing 7.6 when technically the board has already approved a 6.6. Make sense? Now, granted, we're 2 months into this fiscal year. I fully expect, based on what we're looking at, that deficit of the 1 million is how I'm going to describe it right now, to grow. So keep that in perspective as well. But so back to Mr. Touchette's question. So as a reminder, fiscal year 23-24, as I mentioned up above, there was a transfer of $6.6 million from the general fund, okay? Reminder, when we balance the budget for this fiscal year beginning 7/1 of 24, you already approved another $6.6 million, okay? 6.6 plus 6.6 is 13.2 million. That's what's transferred to date from the general fund. That number will likely grow. So I don't want you to compartmentalize it and think of, well, the general fund's only transferred 6.6. I need you to look at the whole sum so that you take a look at the concern. Okay?
Ms. LaBeouf.
Question?
Ms. LaBeouf.
Yes,
So your
ma'am.
13.2, also you would add the other million that you're predicting that's not been transferred, but we're already predicting that you need the other million to hit the 7 point whatever.
Yes, and here's another interesting fact, too, that she just reminded me of. Keep in mind, they're going to audit in the fall. That 2.9 is likely to go away, and it could grow, and you could have an additional deficit on top of that. So you have a lot of concerns here that I want you to keep the bigger number in perspective versus taking a look at the small. I'm not going to, please, I misunderstood by saying small, but the $6.6 million transfers in comparison to the larger numbers is what I'm trying to relay.
Let me, just look,
Yes. So what indications you have right now after 2 months that you are thinking it's going to grow, the deficit? What is causing that only after 2 months?
The claims and billing, the medical and the pharmacy are increasing. Pharmacy in particular, I know we've been focusing on the last board and insurance committee meetings on medical, but your pharmacy is just as alarming. To include the silver scripts, to include some of the rebates that we thought we were going to realize under silver scripts, we're not receiving. We also have, if you remember correct, a couple months ago when HUB came and they spoke about the IRA, that's a new CMS regulation that's passing through effective January 1st, 2025. It's going to heavily impact your health insurance plan. And because CMS, which is Medicare, because Medicare did not approve it till later in the year, we weren't able to add those projections to our budget. It's not in your budget. So that is definitely a concern because it will impact your silver scripts and anybody who's under Medicare. It will impact the district. Let me restate that. It will impact the district.
Mr. Lejeune, and also, when you talk from September to December, historically, when you look at the claims and you look at prescription, we always see an increase at the end. So we're running fiscally, right, July to June 30th, but we run our insurance January to December 31st. So right now, most people have paid their deductible in January.
Mm-hmm.
We do have a rise on these last months with last minute surgeries, and the district is picking up the majority because those people have met their coinsurance, their deductible. So we see a rise. So when you already have a rise and people haven't met their deductible and their coinsurance, we see a greater rise towards the end. You'll see a dip in January a little bit,
Mm-hmm.
and then in February, and then it comes back up. So we already expect a rise, but because of trajectory, we expect a greater rise, I think is what Ms. LaBeouf is saying.
Those are all very good key points, not to mention your active members were out during the summer. Those claims, they likely saw the physician or perhaps had a surgery. So remember we talked about the lagging claims just a bit ago. Sometimes they're 4, 6, 8 weeks in arrears. And based on that, that's coming through at this point in time, and that's why those claims are also increased.
May I?
Ms. Mason.
Just for historical perspective and clarity, and I know we've gone over this a lot in the last 5 years, but is this year out of the ordinary? What kind of deficits have we had before? Is this something that Gallagher is going to cover in their report?
I believe Gallagher will cover that for you, Ms. Mason, during the presentation. They'll add a lot more details to it that you're going to visually be able to see. They can help clarify it for you, and if it's still not clarified, can we circle back to your question?
Right.
Okay.
Thank you.
Thank you. And group benefits, we have not renewed the contract, right? So that 1.2 million that Jeremy spoke of, it's not a bird in the hand. It is going to be a bird in the hand if we renew that contract, correct?
We have renewed it.
We have renewed it?
We
Okay.
have renewed it. That one is the one contract that's off calendar is how I'm going to
Okay.
describe it. It's a 10-1 versus a January 1st contract.
Okay.
It's one of our exceptions, but the superintendent has already signed off on it. Yes,
So the
ma'am.
1.2 will come in our October, were we expected in October or after
We-
October?
We have received it.
Okay.
It is inclusive of the totals that you see ending fiscal year 6/30 of '24.
Okay, great.
Yes,
Thank you.
ma'am.
So, Mr. Hidalgo, let me kind of put things in perspective, because I just really want to make sure that you guys know where we are coming from as an administration, is that, you know, hopefully Gallagher comes up and they talk to us about how we can make sure that we're not in a 13.2 deficit. Every time we sit with the budget, we're looking for ways to, first of all, raise teacher salaries and do different things. You guys come to me every time and you say, hey, we need to do this as far as facilities. This is $13 million. I can stomach $2 or $3 million, but when we start looking at $13 million, it prevents us from looking at teacher salaries. It prevents us from doing things as far as facilities. So I'm looking forward to, and that's why I had Trish come up and front load this for you, is that we have to make sure that when they come up here, they are talking specifically how they think that they can reduce this number, if at all, make sure that we're not even dipping into general fund, because that is where we try to do a lot of different things for you guys. So, Trish, thank you and your team for putting this together and being so, thorough as far as this. And I think this is going to help to kind of get Gallagher where they need to. And I'm looking forward to them specifically talking about how they can get this down for us.
Yes, sir. That's all I have, Mr. Hidalgo.
All right, do we have any other questions from either a board member or a committee member? Okay. Yes. Go ahead.
Oh, I just want to say, I'm going to have to excuse myself early, so, but thank you for everything.
Yes, ma'am.
Yeah. Just bring it to Ms. LaBeouf. So at this time, committee members, if we can take action on this item, the recommended action is that the Board Insurance Committee accept the monthly Fund 85 budget reports. Can we get a motion for that?
I'd like to make a motion to accept the report.
And I'll second it.
All right. At this time, we'll ask for any public comment on the report that was just given. In addition, we do have a question, and so we will also attempt to get that answered here. But if anyone in the audience has public comment on the report that was just given, now's the time to come up. It could be addressed later if necessary. Okay, with not hearing any questions or comments from the committee members, please call the roll.
Mr. Hidalgo?
Yes.
Yes.
Mr. Lejeune?
Motion carries. Thank you. All right, let's move to item 2.4, discussion and or action regarding the Gallagher report. Good morning. If you would please, again, identify yourselves. Welcome. And before you get started, I know that Mrs. LaBeouf has already asked probably 50 times. I'll make it 51. Your report is very comprehensive, and we want to hear everything that's in it. If you could, just get right to it. No fluff. All right, thank you.
No problem at all. We'll go ahead and just start with the agenda. My name is Melody Terrell. I'm a consultant with Gallagher. I have Tony Murray, who will present initially, and then we'll move on to Kim Briard and Lana Labradette. The agenda first, just to let you know the flow, to try to get everybody kind of acclimated to this very long meeting that we're going to have. We're going to go over and kind of get a little bit more into the details as to where you landed at the end of your budget for '24. Then we'll go into some forecasting for '24, '25, and then we're going to kind of give you what it's going to look like in the next few years. We do have considerations for you. You know, we talked about those when we initially came in. We've validated those. We've worked with actuaries, underwriters, pharmacists, subject matter experts who have vetted out these various programs that we think can help control cost. I think one of the questions was, you know, does this look differently this year compared to what it did the year before? The answer is this is a problem, a national problem. This is not a local confined problem. Healthcare industry is a very expensive proposition for employers to continue to pay. It comes with change. When you look back at the healthcare industry years ago, there was only healthcare coverage that provided coverage for hospital only. Insurance companies sent out get well cards. It's quite complicated today. It continues to change, and folks are continuing to try to fight the escalating cost. And so we're here today to specifically tell you what that looks like with the data that we've analyzed. With that, Tony?
Thank you very much. As Trish went over most of this, I do want to say that this page is a summary. Page 52 in the back of your booklet has it broken out by month. The question came a moment ago about when a certain claim hits, so you can, I'll just say that so you can look back if there's any question on a particular month. The main thing I want to direct you to is this is, if you've never seen a financial monitoring report before, this is really like an upside down income statement. And over to the right, I'm sorry, on page 5, over to the left is going to show most of the expenses. And I independently verified, my team and I independently verified each of these. That's when Trish spoke about us reconciling this. We brought in I pulled the reports in from the carriers, when the claims were paid and so on. If you see double asterisks on the left, what that is indicating is those we sourced directly from the LPSS financials for fixed costs, just to make sure that we were recognizing rebates and reimbursements exactly when LPSS was recognizing those. Over to the right, you're going to see the income. And right at the bottom there where you see the budgeted costs, those are the premiums that are being collected. That's from the employees and from the school board. And so you're going to hear me talk about funding. And so when we say you have a surplus or a deficit, and in this case, $7.8 million on the deficit, that is a deficit in the sense of funding. The idea would have been if the premiums had been set correctly in the sense of, or higher, then we would not have had that deficit. And if I go too fast, please slow me down or go through or use any term that you're not familiar with. I'm happy to go through this. So what I'm about to go through is an explanation of how we come to our projection. The very first step is this page shows you June 22nd through June 24th. This is a rolling 24 months of claims. We have subscribers per month, that's employees, then members. Then we have medical claims, pharmacy claims, and total claims. Now, this is gross claims. This is not including reimbursements. This is not including rebates. And if I can direct you to the bottom, we have a prior 12 and a current 12, rolling 12. And we bring these down into what we call a PEPM and a PMPM, or a per employee per month and a per member per month. And I just wanted to direct you to that to follow to the next page. We break that down. This group is very large, so we consider this a credible group over your trend. So these are paid claims. Ms. Trish was talking about when things are recognized. These numbers will match up just as exactly when claims were paid. And so you see at the top, the very first line let me take you first on the left side. These are the items that are going to be trended, which is claims. Over on the right are fixed costs, and we will be coming back to that in a moment. But what we are doing, and one more thing I want to mention, is that this will not be normal for us to come back with a projection this time next year. We wanted to do a look-back projection to make sure that we were on track for this year. This is something that will normally be only done in April for the following plan year. So as you can see on the top left, the box to the left, we've got July 22 to June of 23 on the left. That's the prior rolling 12. And we have the current rolling 12 on the right of July 23 to June 24. So we have these divided left and right there. So we see the gross paid claims. The next thing we do is any prior plan design changes we remove. We do a little bit of deduction from there. We now have adjusted paid claims. The next thing we're going to do is we're going to pull out any rebates or subsidies to get to a net claim number. And the reason we're doing that is because we do not want to trend. We're not going to trend rebates or reimbursements. And the next piece is we're removing the specific reimbursements. So that's your stop loss claims that exceeded your specific deductible of $525,000. Those were those reimbursements, so we pull that out as well. And now we have a total net paid claim. So these numbers will, they do look smaller than maybe you're used to seeing, but that is because these are net. This is after the rebates and the subsidies are pulled out. We then add up all the subscriber months. So what we did is we took all the subscribers in each month, added those up for those 12 months, and we take that total, divide it by those subscriber months, and we get to an average claim value, or a PEPM. So we have medical on the left. In the case of, for 22, you see 508.51. Then you see for pharmacy, 204.23. And then for 23, you see 612.04 and 203.75. Just making sure everyone's following this mess. So then we get, the next thing I'm going to do is where is our experience midpoint for each one? So we see that first 12 is January of 23. The second one is January of 24. And then I need to determine where do we want to project this out to. And our goal was to just project this out to your fiscal year, which will end June 30th of 25. So our projection midpoint would be January of 25. So that shows me next, I'm going to be trending out the data on the left out 24 months. I'm going to trend the data on the right out 12 months. Now, the trend factor that we're using, our actuarial scientists look over our book of business as one of the third largest in the nation. We're also looking at entities of your same industry, in this case, public entity and school boards. And then we're also looking at groups your size. And what we've come up with is we feel that 7.5% medical trend is what we're looking at for next year, and 13% trend in pharmacy. And yes, that is honestly the highest number we've ever put for pharmacy, but it is that big of a crisis right now. Those get converted into trend factors. We're taking that percentage into a trend factor, so now you can multiply the average claim value by those trend factors. We have small minor adjustments and what we call a reserve adjustment. The contract size adjustment is because of that fluctuation Ms. Trish was talking about in people leaving and joining the plan, so that achieves balance for that. And we now have an experience. We've converted this now from paid into incurred. So we now have an experience incurred claims, PEPM. We merge those two together. We now have 850.90 PEPM for the prior 12, 892.36 for the current 12. We feel, based on your size and stability, you are what we consider a creditable group. So we're going to blend that where 90% of the experience we're going to use from the most recent 12. So we take 90% of the 892, 10% of the 850.90, and we now have a projected incurred claims PEPM of 888.22. And if you annualize that on claims, a net claims value, so this is net, is $55,850,842. And I'm going to pause there for just a moment. So that is everything that is trended. And we now have our trend number of where of what we believe our costs will be over through June 30th. On the right side, these are our fixed costs, or because we're the plan is like a mini insurance company. These are the costs that you're paying every month. The admin TPA fee to Blue Cross, to RX benefits, to Silver Scripts, the wellness EAP, your contracted services, such as your consultants, the audit fees, the administration's fees for this department. We have the PPACA fees that we have to pay at the end of the year, your and these came straight from LPSS budget, the prescription drug, what you had budgeted for the Medicare Part D, and then also the refunds to general fund and members and retirement payments. We bring that to a total fixed cost of $5.2 million. We're going to see that on the right for some increases based on this year's budget is $5.6 million or 89.47. So I take that $89.47, add that to the $888.22, and that brings me to $977.68. The number above it, the $855.73, it says current budgeting rate. If you go to the financial monitoring summary earlier, and I was showing you here, right here at the bottom, the premiums on page 5, how many you're collecting, because based on the premium set from what you're paying from the employer side and the employee, add those together based on the enrollment today, and this is what we have based on our, that's how we get to 855.73. So based on your current funding, we are recommending a 14.3% increase to premium. That does not mean, we're not saying that to employee, we're saying that if you budget the premium, because the employer is already paying this, right now you're funding that out of your general fund. So our goal would be to have you not have to borrow from your other funds. And what we're saying is if we get the premium set correctly, we feel like you would not have those deficits. So you've already budgeted for, as Ms. Trish said, the 6.6. So this would then just be that additional piece, and that would then translate into these premiums, and I wanted to make, okay.
We're good? Okay.
And I'm just flipping through page 9, 10, and 11, and that's just showing what the new premium would be. You'll see that the employee stays the same in this case, not making any recommendations other than to the total premium. And then lastly, I'll take you to page 12. And what this is forecasting for you is giving you a 3-year forecast of what we believe based on the current projection of what we feel like it's going to be like. Now, this is, I know no one here is familiar with hurricanes and hurricane projections, but these are about that 2027 projection is about as accurate when the hurricane's out past Puerto Rico. You know, it's going to hit somewhere between Galveston and Fort Lauderdale. But we do believe that we know it's going to increase. I can't give you a precise number, but this is to give you that example of where we think that's going to be. We know it, and the 17, 27, and 39%, that's changed from current. I do want to make sure you don't think that's 39% from 26 to 27. Oh, thank you.
I think the only point to make here is that the same methodology was used that we just went through to project what the new year would look like. That same methodology was used here, except they're just forecasting further in the future.
I think it's getting washed out on that screen.
Yeah, it's being washed out.
Any questions for Tony? We are going to bring up Kim next.
I just wanted you to go a little bit further in the clarification on the projections. So, I mean, obviously, our claim payments are going to go up. The amount of money that our employees and everyone that we're paying into the plan is not going up at the same rate, correct?
Well, what we're saying,
it's just going to keep
what we're
costing
saying,
more and more,
right.
but we're not putting in.
At this point, we're not making, later in the presentation, we'll be talking about considerations.
Okay.
Right now, what we're talking about is this is the cost of the program.
I just want to make sure that becomes very clear.
And
Yes, no, thank you for asking
It is based
that.
on 5,240 employees, so it is a point in time.
Okay, thank you.
Thank you.
Good morning. My name is Kim Briard. I'm a consultant with Gallagher. So after the financials, we really just like to just give you a high level of, where we are in our thought process and how we come to you with solutions to lower that deficit, right? So we understand the magnitude of it, but want to kind of bring that back. So in summary, I think you, as a board, you have some decisions to make, some pretty big ones, right? A couple things that, Ms. Trish mentioned are these deficit numbers. So you ended the year with a $7.9 million deficit. You're currently scheduled to end your fiscal year with a $7.6 million deficit, right? So the question, I think, to you guys would be, do we want to go back and capture the deficit from the prior year? Or are we looking to go forward, right? So those are two very different numbers, but as we go through our recommendation and our suggestions, we are taking into account both of those numbers, right? So that you can return money back to the general fund and use it for other things like books and salaries and those items. So two big funding mechanisms, and while we go through them, we are taking into account both of those numbers. Not only that is the forecast for 2027 is big, right? So we know that you're going to have to make some changes. So the first thing, we looked at is just benchmarking data. It's very important to understand where you are compared to your peers. So with Gallagher, we benchmark against 8 other school boards as well as OGB, Office Group Benefits. They have the majority of the school boards in the state, but we did focus on, a lot of large school boards that are similar of your size to get an understanding of, what their programs look like compared to Lafayette Parish school systems. I do want to point out just a couple of bullets. 3 of the 9 that we benchmarked currently offer high-performance networks. That is an area that we're going to talk about today and a consideration for the board. 5 of the 9 provide plan designs that are comparable to LPSS. These school boards include OGB. Of course, OGB has many plan designs, not just a couple. East Baton Rouge Parish School Board, Central Schools, Lafourche, and West Feliciana. Very few school boards benchmarked a co-insurance less than 70%. That'll become relative later on in our presentation. 5 of the 9 provide triple plan options. 2 of the 9 have plan offerings that cost about $45 per month for employee-only coverage. This is the lowest premium under all the plans that were benchmarked. In general, LPS's employee contributions are superior to the benchmark schools. However, plan designs are slightly inferior to the benchmark school boards. The next couple slides, I won't go through this in detail, but we do want to provide you the plan design for OGB, East Baton Rouge Parish, and St. Tammany Parish, so you can see those. We also are providing the employee contributions so that you can see how they compare to what you're doing today.
Just a point of clarification.
Yep.
When you use the word superior to benchmark school boards, are you meaning that our employee contributions are higher?
No, they're less, right? So it's a
Okay, so
richer,
superior meaning
correct.
less.
Yeah,
Okay.
so you can see on here, you have a plan that it costs the employees $12 on a monthly basis, high deductible plan. And like I mentioned, the lowest one that was benchmarked was $45. Okay, so the first topic we want to talk about is just high-performance networks. High-performance networks, this is a trending strategy in healthcare. Many large hospital systems have developed basically ACOs, right? Where the goal here would be to drive your population to high-quality, low-cost providers. What does that do for your plan? Is it helps mitigate the cost of services in your plan, right? We're looking for quality providers that lower readmission rates, lower reinfection rates. but also provide lower costs to you by structuring your plan to do that. We know that through data, we do see improved outcomes, right? So, a bigger strategy there to help long-term lower the cost. However, in order to take advantage of these high-performance networks, they want you to design your plan design such that we are incentivizing your population to utilize the high-performance networks. And we do that through plan design. The plan design would be tiered in a way where if your members utilize the high-performance network, they pay a lower cost at the doctor or at the hospital or at the facility. Based on your population and where everybody is located, we know we can't offer just the high-performance network, that we do need to keep the national networks in play as well. So today, you're utilizing the Blue Cross PPO network, which is their national network of providers. That will become your Tier 2 network, where your employees and retirees could still access that network, so that we are not removing any providers from your network, right? We're just separating the benefit that they would pay out of pocket if they go to the Tier 1 provider versus a Tier 2 provider. The last tier is your out-of-network benefits. You do have out-of-network benefits today. You will continue to have out-of-network benefits in this plan design. With Blue Cross, and when we looked at your population and where everybody was living, the recommendation in the High Performance Network is a network called Blue Connect, right? It is anchored by Ochsner. Ochsner is not the only provider that's in the network. Their friends and family are also a part of this High Performance Network. I did list out a list of providers there: Savoie, Opelousas, Ochsner, Acadia, Iberia, and so forth, that participate in this network. Many of your employees and retirees are already using these providers, right? So there's a savings there just from the utilization that is happening today that you'll be able to take advantage of if you implement this high-performance network. Across the state, there are 36 hospital organizations 36 facilities that do participate.
So can you just kind of just summarize so that, because people need to get a grasp of what you just stated. You have a Tier 1, you have a Tier 2, and you have a Tier 3. Tier 1 is what?
Blue Connect.
Blue Connect. And that is, we're saying you're going to have a lower cost if you go to these particular providing institutions.
Correct.
Tier 2 is?
PPO, the Preferred Care Network.
Which you're going to pay more.
You're going to pay more.
You're going to pay more to have what you have now. All right? And then, I guess Tier 3 is?
It's just out of network.
You're out of network, and
Yep.
you're really going to pay more.
Yes.
Okay.
And Mr. Touchette, do you mean when paying cost, do you mean the amount of deductible, the amount of co-insurance?
The member's cost.
premium? It's the actually deductible and co-insurance, not the premium.
Yes, ma'am.
Okay, thank you.
Out of pocket. Let me jump in. Just because it's Tier 2 doesn't mean that you're not utilizing Tier 1 could become what is Tier 2 today. I mean, there may be some providers that you're seeing today that fall into Tier 1. So it doesn't necessarily mean that Tier 1 is a new option and it's definitely going to be different than what you utilize today.
Correct.
Okay, and then in addition, do you know that, for example, if someone goes to Ochsner and Acadia or St. Martin or Lafayette, is that all the same coding and the same cost for the exact same procedure, or are there different costs depending on what facility they utilize?
It's actually different. And the reason why it's different is because it's in a different geographical area. So what will happen is when folks like Blue Cross negotiate with providers for discounts, it could be that in certain areas, they don't have to negotiate as heavily, and sometimes they negotiate more. So it could be that when we analyze this network, let's just say in the metropolitan area of New Orleans, that there's less costs differential from the PPO network than there is in Lafayette. But as we analyze that plan, and you'll see this later, it was based on your zip codes, and it's based on exactly where your people are frequenting physicians today. Did that answer your question?
It does. I just
Okay.
want to be sure that this is going to be, just let you guys know that this is going to be a further topic of conversation, because it goes back to, we understand that everybody wants what they want, but the situation we're in now is we're going to have to find a way to tighten the belt. And I really like that we're not necessarily eliminating anything,
Right,
but it's going to be a major difference.
right. But the savings projections that we have are based on these zip codes and where your folks are going, not just randomly picking hospitals, in New Orleans, et cetera.
Okay, so that brings us to the network repricing analysis. So we took your claims data. This data represents incurred claims January of '24 through December of '24 and paid through March 31st of '24. I do want to point out that, just like, you talked about earlier, that there were renegotiations of the Ochsner contract that held up your payment of claims. Those did occur in this market. Facility contracts were renegotiated with a 6/1 effective date, and professional contracts were renegotiated with a 7/1 effective date. We are taking into account those renegotiated contracts this year. So the blue box at the top is just your current claim state. This is not 100% of your claims. We are looking at facility and professional claims. So there are claims that aren't included in this analysis, like ancillary type of claims, durable medical equipment, things like that, right? So, but when we look at facility and professional services, what we're seeing today is that you have about almost 94 million that is hitting in-network. And when we say in-network today, remember that's your preferred care PPO network. The allowed amount for those charges is 33.3 million. That's a discounted rate of 64, almost 65%, which means that your liability is 35.5%. Non-participating, that is out of network, it represents about $900,000 with an allowed rate of $364,000. When we take that 93.8 million and we determine how much of that 93 would hit the Blue Connect network if you had it turned on, you'll see those numbers listed in the green box. So the in-network in the green now represents Blue Connect. 45 million of the 93 is hitting the Blue Connect network today. Your PPO represents the other 48.7 million. The allowed amount of the 45 is 14.6. It's yielding a discount of 67.4%, which means your liability is 32.5. The PPO is yielding an allowed amount of 17.8. The discounted rate is 63.5, with your liability as 36.5. So when we compared the allowed, right, because that is how much the plan is responsible for. The members are going to pay their cost share as well, but that's the allowed amount. We have a difference of $854,000, and that is if you do nothing, right? So the providers that are in the Blue Connect are willing to give you a higher discount for you to develop your plan to incentivize them to go to their high-performance network, right? So that number is about a 2.5% savings just on your data today. The one thing that it doesn't take into account is any migration into that Blue Connect. So we're going to talk about plan design in a minute, but we're going to incentivize your employees to now use Blue Connect. So we know there's going to be some migration, but we're not taking into that account in the migration. The chart, it's kind of small, but the chart at the bottom basically takes into account migration. So you'll see if we get 10% migration, then the district is going to save an additional $196,000. So that would, yield a total savings of a little over $1 million. We move that all the way up 20, 40, 60, 80%. If you were to have 100% migration, you would see a savings of $2.8 million. That's not feasible for the district. You have people that are outside of the service area that will continue to stay in the Blue Cross PPO network. But we just wanted to illustrate as migration goes to the high performance, it does create additional savings to the district.
We had a question behind us, and I just want to make sure it's clarified. The Blue Connect tier is a Blue Cross Blue Shield network. Yes. Does that help clarify? I just wanted to make sure.
Okay. Perfect. Okay, so we're going to move into plan design, okay? The one thing to note on this page is that in the plan design that we're talking about today, we're not recommending any changes to your pharmacy benefits, right? So your pharmacy co-pays, deductibles, those stay the same because we're really just talking about your medical network and not your pharmacy. Question on that?
So the question is, why are we not looking at everything?
We're going to talk about pharmacy later, but in this high network analysis, the pharmacy is staying the same. Okay. This is just a snapshot of your current benefits and then the recommended changes to your benefits that I believe was approved by the board for January 1st effective date. Really just moving your deductible for the basic plan from the $950 to the $1,200 deductible. For family, it was $2,850 to $3,600. And then under the enhanced plan, there's a proposed benefit change there from $800 to $1,100 and $2,400 to $3,300. The plan design for the high performance network, like I mentioned, is going to be tiered. So what we're illustrating here is just your two tiers. Tier 1 would be Blue Connect. Tier 2 would be the preferred PPO. Everything that you see in red is a change to what you're currently doing today. Tier 1, under your basic plan, would have a $1,200 deductible for individual, a $3,600 deductible for family. The coinsurance is 80/20. We are recommending a change to your emergency room benefit. Today, you have a $50 copay. That $50 copay is not in line with the market. We see a lot more cost share when somebody needs to use the emergency room. Unnecessary emergency room utilization does drive your healthcare cost. So while we want to create a benefit there, we don't want to incentivize your employees to use the emergency room versus a PCP or an urgent care. So our recommendation there is to change the deductible, change the benefit to deductible plus 20%, just like your inpatient and your outpatient services. Tier 2 for the base plan would have slightly a higher deductible. That deductible would be $1,400 for a single, $4,200 for a family. Your coinsurance would move to 70/30, so the plan would pay 70%, the member would pay 30%. The out-of-pocket maximum would increase from $5,500 to $6,600 for a single and $11,100 for family to $13,320 for a family. The enhanced benefits would basically do the same thing. It would increase slightly on the deductible to $1,300 and $3,900. This plan does have copays for primary care and specialists today. They would pay a little bit higher for those copays in Tier 2. The out-of-pocket maximum would also go from $4,750 to $5,750, $11,100 to $13,320, and the coinsurance would also change to 70/30. Your high deductible plan would go from a $2,500 deductible, $5,050 for family, to $3,000, $6,000. Your coinsurance would change from 80/20 to 70/30. Your out-of-pocket would also change from $5,000, $6,000 to, for single, $10,500 for family to $12,000 for family. When we make all of these benefit changes, we would see an additional savings of $1.8 million in plan design changes. I'm going to pause there for some questions.
That's huge. And all we keep doing every year is raising premium and reducing benefit. Now, I'm going to presume that there's still a lot left in this packet, so I'm going to assume that there are going to be some other ideas, like direct negotiations, et cetera. But, and I know that we're at the last minute for this next cycle, but guys, you know, this is huge. This is ridiculous. And this year, I'm going to use myself as an example. So finally this year, I've had significant trips to the doctor. Okay, a lot of money out of my pocket. I'm on the high deductible plan. It is ridiculous what it's costing our people, and I'm not talking about in premium. I'm talking about out of pocket. So we're doing all of this, which is huge, for $1.8 million when we have a $9 million deficit. So I just wanted to share my concerns so far. You gave it a pause. This is actually a great time. We're going to take a 5-minute recess for folks to go use the restroom, grab a sip of water. We've had a couple that asked. So actually, we're going to take a 6-minute recess. We'll be back in 6.
Are you? We'll answer your question right after.
Why don't we start off that we, push it.